So, Bismillahir Rahmanir Rahim, in the name of God Almighty, the most merciful and the most beneficent. Ladies and gentlemen, on the behalf of President, Pakistan Society of Hematology, I welcome you all to the 7th webinar organized by PSH. We are very lucky and honored to have professors of world fame on the subject of chronic myeloid leukemia today. So we have 3 talks. First of all, we have Professor Timothy Hugh from School of Adelaide, Medical School of Adelaide, Australia. So let me introduce you all to the Professor of World Fame. Professor Timothy Hugh is the Precision Medicine Team Leader. He is Beat Cancer Professor at the University of Adelaide and Consultant Hematologist at Royal Adelaide Hospital. He's also chair of International Chronic Myeloid Leukemia Foundation, ICMLF, and I myself have availed a scholarship of preceptorship program of ICMLF with Professor George Cortes in MD Anderson Cancer Center, Houston, Texas. So ICMLF is doing a great job. Professor had a significant leadership role in the establishment of molecular response criteria and kinase domain mutation screening guidelines that are used worldwide to monitor response and resistance in CML. He has been a key principal investigator on many of the global and Australian CML trials that have shaped the way tyrosine kinase inhibitors are selected and sequenced. He has been a leader in the area of treatment-free remission TFR and influential in the recent recommendations to make a TFR mainstream goal of the therapy. He has published more than 300 peer-reviewed articles in the world-renowned journals, and we are very lucky and honored that Professor Tim Hugh is with us. Over to Professor Tim. Thank you very much, sir. We are really honored.
Thank you very much, Dr. Marine. It's great to be invited. Thank you, Professor PARVEZ, as well, for the invitation from the Pakistan Hematology Society. I have had invitations in the past and not been able to come personally to Pakistan. So it's great now that we can do everything by webinar, that it's possible to join you. And it's a great honor for me to do that. I'm going to attempt to share my screen now. We'll see how that goes. Looks promising. Share.
Yes, we can see it now.
Okay. Beautiful. So that's clear to you. The slide is, you can see the slide of my institution.
Yes, Tim, it's very much visible and beautiful institute photo is there. So yeah. Thank you very much. Carry on.
Thank you. Thanks very much. So this is the place that I work, the South Australian Health and Medical Research Institute. It's right next to the new Royal Adelaide Hospital, which is a $2 billion hospital just recently built. And we do most of the research that is linked to the hospital in this very space age looking building. It's quite an exciting place to work. Now, today I want to focus on diagnostic and response evaluation for CML, what's new, particularly referencing my talk to the ELN recommendations that have just come out in leukemia, the 2020 recommendations, but also, of course, the NCCN recommendations from the US group that tend to be quite similar, but we'll compare some of the different recommendations. So the process of developing the European recommendations is quite a lengthy, could say painful process. We've gone through it now 4 times. There's been quite a big gap between these recommendations and the 2013 recommendations. And to develop a clear consensus, many rounds of questions and face-to-face meetings have occurred to develop the what we hope would be the very strongest evidence we could put together for how to manage patients with chronic myeloid leukemia. And it's worth just reviewing the recommended workups at diagnosis, the things that are critical to perform. And I don't think there'll be any great surprises there, that measuring the spleen and liver size is a critical part of the initial examination, certainly the spleen size to determine the SOCAL or the ELTS score, clearly a complete blood count, and bone marrow aspiration is still regarded as a critical part of the assessment to determine whether the patient is truly in chronic phase or has progressed beyond chronic phase. And there was no definite recommendation that a core biopsy or a trophine needs to be done, but it certainly should be done if there is a dry tap with the aspiration. It is critically important that you do chromosome banding because additional chromosomal abnormalities do have a significant negative prognostic impact for patients with CML. FISH is only really indicated in patients who have a Philadelphia negative but have typical chronic myeloid leukemia. So we very rarely perform FISH today. But it is critically important that PCR is conducted before you start therapy to make sure that you're measuring the predominant transcript, which in the vast majority of patients will be the E13A2 or the E14A2 transcript. But in about 5%, you'll see other transcripts, and they need to be determined at the start of therapy because it's quite dangerous to think that you're following the main transcript when you're not. You may think your patient's in a deep response when in fact they haven't responded at all. So it is a very important part of the initial assessment. An ECG is very important. A lot of the drugs we use prolong the QT interval. So it's important to document whether there's any evidence of heart block or prolonged QT. And of course, biochemical profile, including lipase, because lipase elevation is a frequent complication of tyrosine kinase inhibitor therapy, determining whether there's any evidence of diabetes, looking at the cholesterol. And of course, hepatitis B serology is important because hepatitis B can reactivate in the presence of TKIs, and you need to know whether that's a risk in your particular patient. So what are the treatment goals today for our patients with chronic myeloid leukemia? Well, these are the treatment goals that are listed by the ELN. Of course, the number one goal is survival. We want our patients to avoid progressing to the blast phase of the disease, because that is, even today, is still generally or very frequently a fatal complication. So associated with that, we want to achieve progression-free survival. But very important, we also want to maintain good quality of life. And for most patients, that's possible, but some of these drugs do have day-to-day toxicity that impairs quality of life. So good tolerability is very important. A lack of long-term toxicity, particular vascular toxicity. We'll talk about that in more detail during the talk, but that is one of the challenges, particularly we see in Western countries, higher incidence of heart attacks, strokes, peripheral vascular disease in patients who are taking second or third generation tyrosine kinase inhibitors. But increasingly, a goal of therapy today is the aim of achieving treatment-free remission. And I'll be interested to hear the perspective from the Pakistan hematologist as to whether that's something that they aspire to today for their patients. Clearly, costs can be important. We have a generous health system in Australia where the cost of the drug is generally covered by the government, but that's not the case in many countries. So some of the key statements that have been made in the ELN 2020 recommendations. Firstly, that treatment-free remission should be a new goal of treatment. Secondly, that assessment of patient risk status should be based on the ELTS score and not so much today on the SOCAL score. And I'll show you some evidence for that and how those two scoring systems compare. Thirdly, monitoring response today should, if at all possible, be done by real-time quantitative PCR rather than by cytogenetics or FISH, if at all possible. And I guess the other key finding where we did reach consensus was that EMR failure, which means having a BCR-ABL value greater than 10% on the international scale after 3 months of therapy, if it's confirmed on a second test, that represents treatment failure, and in most cases will be an indication to switch to a different TKI if that is possible. So this is a direct quote from the final document. The ELN panel agrees that treatment-free remission is a significant a new significant goal of CML management, it recommends consideration of treatment-free remission in appropriate patients after careful discussion, employing the concept of shared decision-making. So it's not a decision that the clinician makes and hands down to the patient. It's not a decision that the patient makes on their own. It's a joint, ideally, it's a joint decision that's made after full discussion with the patient about the risks of trying to stop therapy, weighed up against the risks of continuing therapy indefinitely. Secondly, treatment may be changed to a second-generation TKI for a patient who's on imatinib, not just for patients with treatment failure, but to improve the depth of response in selected patients in whom deep molecular response has not been achieved. Now, it's important that the emphasis on selected patients. Not every patient is a good candidate to switch to a second-generation drug, particularly if there's a high risk of vascular toxicity, such as older patients or patients who have already had pre-existing vascular events. That would weigh very heavily against a switch to a second-generation drug. But I think that is an important new conclusion from the ELN, that it's not only treatment failure that is an indication to switch to a more potent drug, but failing to achieve deep molecular response in patients where treatment-free remission is a key goal of therapy should be considered as a pathway towards switching to a second-generation drug in selected cases. So this is a comparison of the SOCAL and the ELTS score. And what you'll notice is that you use exactly the same clinical variables in both scores. So you need to know the age, the size of the spleen measured by palpation from the costal margin, the platelet count for treatment, and the percentage of blasts in the blood. And by using those four factors, feeding those into the equation, which you can do online, there's numerous websites that allow you to automatically calculate the SOCAL score. That divides patients up into three groups: low, intermediate, and high. Now, ELTS is really an improvement on the SOCAL score because it was derived from patients who are on tyrosine kinase inhibitor therapy, predominantly imatinib. And it was focused on, can we develop a better predictor for leukemia-related survival or leukemia-related deaths? And in fact, using exactly the same four parameters, but putting a different weighting on each of those four variables, you come up with a score that once again it categorizes as low risk, intermediate, and high risk. So why do we think that ELTS is better? Well, I think this table from the paper provides convincing evidence. If you look at the lowest row, the 6-year LRD. LRD is leukemia-related deaths. So look firstly at the SOCAL score. In the low risk, 3% of patients have a leukemia-related death. In the intermediate, it's 4%, and in the high risk, it's 8%. So there is a difference, but it's not a dramatic difference. And now look at the situation with the ELTS score alongside the SOCAL score. So for low-risk patients, it's even lower risk of leukemia-related deaths, just 2%. It's about the same for the intermediate, about 5%. But now with the ELTS, we have 12% who have leukemia-related deaths. So that's now starting to get a significantly high rate of leukemia-related death in that high-risk group. So it does provide better discrimination between the low risk and the high risk. It's particularly good in older patients where SOCAL tends to push a lot of patients into high risk who are probably not high risk. So I'd recommend that you look at the ELTS score in your patients before deciding which drug to use. And our general practice in Australia, and this would depend a lot on the availability of drugs in your own situation, but patients with a high ELTS score, we would tend to use either dasatinib or nilotinib as our frontline therapy. We don't have bosutinib available in Australia, so we tend to use one of the second-generation drugs for patients with a high-risk ELTS score, and we tend to favour using imatinib for patients with a low ELTS score because the risk of progression is so low, it's hard to argue for using a more potent drug up front. intermediate, you can individualize the approach. But of course, the decision about which drug to use frontline is not just a matter of whether the risk of the disease is low, intermediate, or high. It's also a matter of whether the risk of vascular disease is low, intermediate, or high, because that will also determine how ready you would be to use a second-generation drug. And of course, the other consideration is other comorbidities, such as lung pathology, that would steer you away from using dasatinib. But the other really important parameter to consider for these patients is whether you have a priority for achieving treatment-free remission. If it's a young female who wants to have a family, the ideal circumstance would be to achieve treatment-free remission so they can go ahead and have their family without having to stop and start TKI therapy. So in that setting, we would tend to use a more potent drug, even in the low-risk LTS setting. So I think that's an important consideration. So this is the new milestone chart for the ELN recommendations. And you see, once again, we have an optimal, a warning, and a failure. And patients who are in the failure category would be generally recommended to switch therapy to a more potent drug, if at all possible. And you'll see that's actually fairly similar to the 2013 recommendations. In fact, the optimal scores are probably almost exactly the same. To be optimal, you need to be less than 10% BCR-ABL at 3 months, less than 1% BCR-ABL measured on the international scale, less than 0.1% at 12 months, which is major molecular response, and in fact, less than 0.1% at any time. But there is a difference now in terms of treatment failure at 3 months. In 2013, the criteria for treatment failure was that the patient was not in a complete hematological response, or they had greater than 95% pH positivity. That's now changed, and the only criteria for failure at 3 months is that the patient has greater than 10% BCR-ABL, and that is confirmed within 1 to 3 months. And we would generally do the test again 1 month after the 3 months, so at 4 months, because if a patient needs to switch, you don't want to wait till 6 months before you switch. But some of those patients will have fallen below 10% by 4 months, and it's perfectly appropriate in that setting to continue your current therapy. Oh, the other thing which is worth mentioning is that it also states that for patients aiming for treatment-free remission, the optimal response is not 0.1%, but is 0.01%, which we call MR4, representing a 4-log reduction from the 100% from the starting level. So that in patients where you are targeting treatment-free remission, an optimal response is in fact below 0.01%. And they further state that a change of treatment may be considered if major molecular response is not reached by 36 to 48 months. It's a fairly conservative statement. In our own practice, we would tend to say by 18 to 24 months, if they haven't achieved major molecular response, we'd be looking at switching their therapy or increasing the dose. So this is really a graphical way of representing that same data, where in the red zone is treatment failure, in the yellow zone is a warning. The patient may well cross into the red zone at any time point, and perhaps it's appropriate to do more frequent PCR monitoring. And if the patient's in the green zone, it's optimal, and you can be happy that their outlook in the longer term, as long as they stay on TKI therapy, is extremely good. Now, this is the milestones if your focus is only survival. If your focus is also treatment-free remission, then you see that change from in the warning category, it broadens out so that 24 months, you want the patient to be achieving a 4-log reduction, or you start to consider whether they may need to switch to a more potent drug. Now, the NCCN from guidelines from the US groups is actually remarkably similar in terms of what they regard as yellow, which is optimal, green, green, which is optimal, yellow, which is a warning, and red, which is treatment failure. And I won't go through them in detail, but they actually are quite similar to the ELN recommendations. Now, we now have recommendations from both the ELN and the NCCN about the eligibility for treatment-free remission. And they both agree that it's mandatory that the patient is in chronic phase and that they've never had accelerated phase or blast crisis. There's no data that would reassure us that it's safe to stop a patient who has had accelerated phase or blast crisis, has gone back into chronic phase, and by other criteria might be eligible for treatment-free remission. We wouldn't consider that because we don't yet have data to tell us that it's safe to do. Second criteria would be that the patient is motivated. I don't think we should be dragging patients reluctantly into treatment-free remission today. It should be something that when they look at the evidence and they are convinced that it's an appropriate thing to do. In many cases, they will have significant toxicity associated with their drugs that is motivating them to look at stopping drug altogether. It's also absolutely critical that you have available at your site or can get in rapid time PCR analysis with great sensitivity, at least MR4, ideally MR4.5, with a rapid turnaround. It's not much good if you have to send your PCR results off and get a result back in 2 or 3 months. If patients are not successful when they stop drug and if they have molecular relapse, it's often very rapid, and it's critically important that you recognize that as soon as it becomes obvious. In fact, if they lose major molecular response, they should go back on their TKI therapy. They need to have what's called a typical transcript. That means either the E14A2 or the E13A2 transcript, because that's the one that we can measure on the international scale, and that's where we have all the evidence of the safety. We don't know whether patients with other transcripts we can't measure so accurately can be safely stopped. That would only be done in the setting of a trial. Now, they also recommend that these are patients who have achieved their deep response on first-line therapy or on second-line therapy if they were intolerant to their first-line therapy. The NCCN doesn't actually make a recommendation on this basis, and certainly in our own practice, if a patient has had a warning on their first-line therapy, say imatinib, and we've switched them to a second-line drug and they've achieved an excellent response, we would consider them eligible for treatment-free remission. So we differ slightly from the ELN recommendations. But it's also regarded as mandatory that the patient has at least 2 years maintaining deep molecular response before you consider stopping their therapy. Now, there have been some trials where patients in major molecular response have stopped therapy, but most of those patients will relapse. So you need consistent values every 3 months, ideally, demonstrating values of below 0.01% on international scale, or the patient's not eligible for treatment-free remission. Furthermore, ELN would recommend at least 5 years of imatinib has been given, and at least 4 years of a second-generation drug, whereas NCN just require at least 3 years. There's some difference there. Now, we go beyond mandatory requirements to optimal requirements. What are the things that they would ideally like to see? And ELN would like to see at least 5 years of drug. They'd like to see at least 3 years of continuous MR4 and or at least 2 years of continuous MR4.5. So that's the criteria that we use for treatment-free remission in Adelaide. 2 years of being below 0.0032% on every test. And on that basis, we have a success rate of around about 60% when we stop drug. So I think this is all very clear-cut, and there's good consensus, although you have some minor differences between ELN and NCCN. But I think now we can regard treatment-free remission as a mainstream activity as long as you can adhere to these criteria. Most importantly, high-quality, sensitive, rapid turnaround quantitative PCR. So how do I think about treatment-free remission in my patients? Well, I start thinking about it on day one. This is the sort of response that I want to see my patient achieve. You can see that they'll start somewhere around 100%, some higher, some lower, but we want to see them fall below 0.1% as rapidly as possible, and then get down to a deep response. Now, initially, at diagnosis, I try and assess with the patient how important it is for them to achieve treatment-free remission. And if it's an 80-year-old patient with diabetes and vascular problems, I'm not really focusing on treatment-free remission. I'm focusing on using a drug that'll give them best chance of survival and minimizing toxicity. But if it's a 25-year-old female, I'm highly focused on treatment-free remission because of the family issues. and really all young patients, I have a high priority for treatment-free remission. But it's a discussion to have right at the start, because as I've already explained, one of the reasons I'd want to use a more potent and potentially more toxic drug would be because of this aim to get a patient to treatment-free remission in a reasonable time period. So that is relevant right at the start. Even though I'm telling my patient that one day he might be able to stop, I tell them that's only going to be possible in 4 or 5 or 6 years if they take their drug every day. So I see it as a way of increasing the adherence to drug therapy rather than reducing. And as they maintain therapy, I'm trying to optimize their response to give them the best chance of becoming eligible for treatment-free remission. And once they achieve and maintain a deep molecular response, I want to document that every 3 months so I can be sure that my patients are eligible for treatment-free remission as soon as they have had 2 years of MR 4.5 or 3 years of MR4. And once they reach that point of eligibility, I find it's important to have a shared decision-making process with the patient. Explain the risks involved in attempting treatment-free remission, but also explain the risks involved of continuing drug long-term. And I find the vast majority of my patients, when they're eligible, are very keen to attempt treatment-free remission. And clearly, when you stop, this is the response you want to see: monthly testing for the first 6 months, 2 monthly out to 12 months, and then 3 monthly if at all possible. And many patients will achieve this ongoing deep response going out for many years. Some of my patients now are well beyond 10 years off drug. But of course, incredibly important that you continue to monitor, because there are some patients who have relapse 2, 3, 4 years after stopping, rarely beyond that, but we don't know the very long-term outcome. So we need to keep monitoring our patients at least 3 monthly, and arguably beyond 10 years every 6 months. But of course, about half the patients will have a rapid molecular relapse. They go above 0.1%, they need to go back on their drug. And then they, in 95% of cases, will once again achieve their deep molecular response. So the conclusions from the ELN 2020 recommendations are that there's a primary role for molecular monitoring to manage our patients optimally. The confirmation that EMR failure being greater than 10%, if it's confirmed, implies a switch of therapy. At the frontline decision-making should be based on ELTS, the priority for treatment-free remission, and comorbidities. And recognizing the key goal of treatment-free remission, as long as there is the specified eligibility. Okay, so in my remaining 10 minutes or so, I want to just go through a case or two. And this is the first patient. This is a 32-year-old lady diagnosed with chronic phase CML, and her ELTS score was low. So we know her risk of leukemia-related death is only about 2% over the long term, over the 10 years. She received imatinib 400 milligrams daily initially. After 3 months of therapy, her level of BCR had fallen from 25% down to 12%. So it's still above 10%. She hasn't achieved early molecular response, or EMR. Her tolerance to imatinib is good. So your options would be, I don't think we have the capacity to vote, but have a think about what you would do. Would you repeat the test in another month before deciding whether to switch? Would you repeat the test after 6 months rather than after another month? So wait another 3 months. Would you increase the dose of imatinib to 600 or 800 if that's possible? Would you switch to a second generation drug, or would you switch to ponatinib given the poor response that they've had so far? So my response to that would be, we would generally in this situation try and confirm the EMR failure with a test at 4 months, so number 1. And that's what we did. The test was repeated at month 4, and the value was 16%. So in fact, it hadn't even improved, it had gone up a bit. This is clear evidence of treatment failure. And for this patient, we switched to what I would regard as the most potent second generation drug. That's nilotinib at a dose of 400 milligrams twice daily. I'd very rarely use that high dose of nilotinib because of the high vascular risk involved, but in a 32-year-old female who had clear evidence of EMR failure and treatment failure, I think that'd be appropriate. So this is a second interactive case. This is a 54-year-old male with chronic phase CML, diagnosed in 2015, and his ELTS score was intermediate, but he also had a low Framingham risk score. Now, you may or may not be familiar with the Framingham risk score, and I'll describe what that is in a moment, but that's assessment of his vascular risk, because I always want to know what the risk of a patient's developing CML problems, but also vascular problems associated with the drugs. Now, because this patient had a low Framingham risk score, we prescribed nilotinib, 300 milligrams twice daily. And in fact, they had an excellent response. They achieved MR4 after only 1.5 years, so below 0.01%. And after 5 years, they've maintained MR4 for the last 3.5 years. So the question is, would you consider them for treatment-free remission? So this is the actual chart of their molecular response. You see at diagnosis, the value was 290%. We often get high values at diagnosis because our control gene is BCR, not ABL. If you use ABL as your control gene, this would tend to be more suppressed and not so often above 100%. But you can see that that's fallen by 3 months to 0.26. That's a dramatic fall over the first 3 months. Following that, the patient got down to MR4 at 18 months and down to MR4.5 at 30 months. So he's had 3.5 years of MR4 and 2.5 years of MR4.5. Now, after 5 years, he's keen to attempt treatment-free remission if that's what we recommend. And there are some vascular concerns, even though he had a low Framingham risk score. He's had a younger brother who's just had a coronary stent inserted. And he's now, this patient is being treated for hypertension and for an elevated cholesterol. So the question is, would you recommend treatment-free remission now? And if you don't recommend it, or if the patient doesn't want to go that way, would you continue the nilotinib, or would you reduce dose, or would you switch him to a less toxic drug in terms of vascular toxicity? So the options would be proceed to treatment-free remission attempt now, continue the nilotinib, and consider a treatment-free remission attempt in 1 to 2 years, continue nilotinib long-term, and don't regard treatment-free remission as a priority here, or switch to another TKI because of concerns about vascular toxicity. And my response in this case would be to proceed with treatment-free remission. But if the patient was not keen to pursue that, then I would actually consider either reducing the dose of nilotinib or switching to imatinib, which may be able to maintain, would very likely be able to maintain a deep response in the longer term. Now, just to remind you about the results from the Ensnd study, we now have 10-year data, and it clearly shows that patients who received the more potent drug, either 300 twice daily or 400 twice daily of nilotinib, have a significantly higher rate of achieving MR4.5, which, as we've said, is one of the requirements to contemplate treatment-free remission. So the benefit was already there at 5 years, and it's the same gap you see now at 10 years. It hasn't closed, in other words. The patients on imatinib have not got up to the same level as the patients who received nilotinib front line. So at 10 years, the rates of MR4.5 are in the around 60% with nilotinib at either dose versus around 40%. So it's a significantly higher number of patients that you may be able to get to treatment-free remission within those first 5 to 10 years. But of course, progression-free survival is not different, even though we know that nilotinib does reduce the number of patients who transform to accelerated phase or blast crisis. There is an equal and balancing higher rate of toxicity with nilotinib compared to imatinib, so that overall the progression-free survival and the survival is no different with these drugs. So you don't use nilotinib because you want to achieve a better progression-free survival or overall survival. You generally use it in most patients because you want to achieve a better probability of treatment-free remission. So what is this the problem with vascular toxicity. Now, nilotinib, and we believe dasatinib has similar risk of vascular toxicity, and it's probably less with bosutinib. And I don't know how much this applies to a Pakistan population. It does seem to apply to many westernized countries. The risk of a vascular event in the first 5 years, this can be a cerebrovascular, acute myocardial infarction, peripheral vascular disease. It's only 1.8% over 5 years with imatinib. So that's our sort of benchmark. With the standard dose nilotinib, it's 7%. With the higher dose nilotinib, it's almost 12%. And then what happens in the second 5 years? Does it go down to any lower level? Well, with imatinib, it's still 1.8%, and it's still high, 9% over those 5 years with the lower dose nilotinib, and 12% with the higher dose. So it's not as though the risk gets any lower over time. Now, I wanted to briefly mention, while I've got the last 5 minutes, the Framingham risk category. So this is the thing that I calculate for all my patients, and it's pretty simple. You look at the age of the patient, you look at their cholesterol level, their blood pressure, whether they smoke or have diabetes. So the patient that we've discussed here, at diagnosis, he was 54 years old, so that gives him a score of 8. He had a mildly elevated blood pressure, which gives him a score of 1. So his Framingham score was 9, which puts him in the low risk category. Now, reassuringly, patients in the low risk category, even if they receive nilotinib for 5 years, still have a very low risk of vascular events. Whereas patients who have intermediates or high Framingham risk score, it's a very significant price to pay in terms of vascular toxicity by using a drug like nilotinib and arguably dasatinib. So this is, I think it's an important thing to know. But it's also important to know that this is the 5-year data. Over 10 years, this sort of safe profile for patients with a low Framingham risk is not so evident. For the patients with a low Framingham risk over the 10-year period, if they receive imatinib, they've got a rate of just 1.1%, but it's 6 times higher if they receive nilotinib, even if they started their drug 10 years ago with a low Framingham risk score. And that's because I presume a lot of patients will, because they get older, they get blood pressure and cholesterol elevations, their risk score elevates over time, and they become at risk of this vascular toxicity. So I'm going to fast track through a few of these slides because I want to come down to the key recommendations.
Professor, it's fine. If you want to take more time, it's fine with us because we have 2 hours for 3 speakers.
Okay. All right. If I'm still within time, then I'll come back to this. All right. So coming back to our patient, just looking at these, his molecular response, and just noting that dramatic fall over the first 3 months. And we've found that to be really a very important predictor of outcome. This is now just coming out in Press in Blood, the findings that from our study of our patients, looking at the slope over those first 3 months. That means you have to do a PCR at diagnosis, which a lot of people don't do. But I would recommend that you do it, because I think it does provide some added information. And this is the paper that we've just published. Early BCR-ABL kinetics are predictive of subsequent achievement of treatment-free remission in CML. So this is asking the question, is the tempo of the molecular response in the first 3 months predictive of sustained treatment-free remission for patients who are eligible? Now, what do we mean by tempo? Well, there's 2 patients here that I've given in the example. 2 patients who started at 100%. One of them got down to 10% at 3 months. One of them got down to 0.1%. If you calculate how rapidly that the number of transcripts halves in the blood, that halves every 27 days in this patient and every 9 days in this patient. So this patient's got a rapid halving time. They halve every 9 days. This patient has a slow halving time. And that actually is a very important biological observation. Now, you also have this situation, 3 patients who at 3 months have the same value. They're all 1% at 3 months, But because they started at a different value, this patient started at 10%, this patient at 100, this patient at 300%, the slopes are actually very different. So this patient, even though he's down at 1%, which looks pretty good at 3 months, because he only started at 10%, the actual slope is 27 days. It's just as bad as going from 100% down to 10%. Whereas this patient, who's 1% at 3 months, because they started at 300%, has a rapid halving time of 11 days. So it's possible to calculate this halving time, and the way to do that, the formula is in the paper. And what we found was quite remarkable. The patients who became eligible to stop, that had at least 2 years of MR4.5, they stopped their drug, and the patients who relapsed, and most of them relapsed within the first 6 months, but their halving time, way back in the first 3 months of their therapy, for some of those patients it might have been 10 years ago, for some patients it was 5 years ago, but looking back at their halving time, all of these patients who relapsed had relatively slow halving times. The median was about 20 days, whereas the patients who were successful at treatment-free remission, nearly all had rapid halving times. The median was 10 days. So this was, I think, a really important finding, and it pretty puts the focus back on trying to achieve a really deep response in those first few months has positive outcomes for the patient, not just in terms of avoiding progression, but also in the likelihood of achieving eligibility for treatment-free remission. But even if they're eligible for treatment-free remission, the likelihood of success. So here is, we've divided patients up according to which quartile they were in for halving time. So the patients who had the shortest halving time, which was Q1, they're less than 9 days, if they became eligible to stop, the chance of success were better than 75%. By contrast, the 25% of patients who had long halving times, more than 21 days, even though these patients were just as, they looked just as good on paper, they had achieved MR4.5, they'd maintained it for 2 years. But when you stopped, they had about a 10% chance of success. So I think it's very, very helpful indication of the patients who you should consider strongly for stopping, and who you might need to consider perhaps longer therapy before stopping, or perhaps we need to do something different for these patients. Now this needs to be, we did validate this with the Korean TFR group, but we need more data to I think, before we start to use this in our clinical day-to-day practice. But I think it's interesting, and I'm happy that I have been allowed the time to talk to you about it. So that provides then a predictive chart where you can calculate the patient's halving time. And the example that I gave, now it's assuming that the patient has maintained MR4.5 for 3 years. If your halving time, in this patient, the halving time was 9 days, because they went from 290 down to 0.26. So according to that, with 9 days halving time, the success rate is greater than 75%. Whereas if they had a 25 day halving time, the rate of success would be something around 25%. So I think this is quite a useful chart for people to use. But as I said, it needs further clinical validation. So coming back to our patient, the patient and the clinician decides against treatment-free remission. Even though I've told him that he has a 75% chance of success, he's basically said, look, I'm happy on my drug, I'm just going to continue. Then what are you going to do? You're going to continue the full dose of nilotinib and try and optimize their vascular risk. So treat their high cholesterol, their elevated blood pressure aggressively, make sure they're exercising, they've got a healthy diet. Well, I'd be worried about that given the data that I've just showed you on the 10-year data. Could you reduce the dose? Could you switch to low dose to dasatinib? That's an interesting possibility, but unproven. Or could you switch to imatinib 400 a day? I think if the patient has no interest in stopping at any stage, I can't see any strong argument for maintaining nilotinib. I would probably switch them to imatinib. But in this particular patient, he thinks he might want to stop in a year or two, then I'd reduce his dose of nilotinib just to try and reduce that risk of a vascular event. I think the evidence that the the dose of nilotinib is strongly linked to the risk of vascular events, encourages me to believe that using a half dose of nilotinib, as long as it maintains response, would be a reasonable way to reduce the risk of a vascular event. So the conclusions from the Ensnd 10-year data that I've briefly shown you are that the gap in the MR4.5 rates over time between nilotinib and imatinib stay the same from 5 years to 10 years. The cardiovascular event rates on nilotinib remain similar in the second 5 years, something that I was hoping to see would come down, but it doesn't. Patients with a low Framingham risk score have a low risk of cardiovascular events with nilotinib over the first 5 years, but you can't say that over the full 10 years. And for that reason, even patients with a low Framingham risk score, when they enter the study, I would be very cautious about giving them more than 5 years of nilotinib, unless they are on the brink of going to a treatment-free remission attempt. Second lot of conclusions, the tempo of the initial response has a strong impact on long-term outcomes, including treatment-free remission. I think that's a fascinating finding that warrants further investigation. If the goal of treatment-free remission, if the goal is treatment-free remission within 5 to 10 years of starting therapy, then the evidence is pretty strong that a second-generation TKI is likely to give you a better chance of achieving treatment-free remission. But the vascular risks versus prospects of treatment-free remission need to be carefully calculated for each individual patient to make sure that you're using the most appropriate drug throughout the patient's journey. Just giving a couple of quotes from the ELN 2020 paper, the goal of therapy is normal survival and good quality of life without lifelong treatment. That's a very important addition to what's been said in the past. And the vision for the next 5 years is that more CML patients will successfully achieve treatment-free remission, and that it'll be possible to talk more confidently about the curability of chronic myeloid leukemia. I want to acknowledge that the halving time data that I presented was conducted by Narani Shanmuganathan in the laboratory of Susan Branford, and we validated the data using the South Korean cohort that was under the care of Dr. Dong Kim and colleagues. And I thank you for your attention, and I'm happy with any time. I'm happy to answer any questions.
Thank you very much, Professor Timothy Hugh from South Australian Health and Medical Research Institute. It was such an enlightening talk. It was a mesmerizing and fascinating talk about treatment-free remissions, which we have not even yet. So we are really educated upon this topic. If you allow, I would just discuss a very brief case about a 7-year-old child with chronic myeloid leukemia. He presented with a WBC count of 600 in chronic phase, and we started him with imatinib, that is 260 milligram per meter square for pediatrics. And after 3 months, he was not showing optimal response. And even after 6 months, lack of optimal response led us to switch to nilotinib. And even after 6 months of nilotinib, his quantitative PCR-BCR-ABL is still 3%. So the child has 2 more siblings, both are haplo-matched. One is 5 years and the other one is 2 years. So now we are at a point to, we don't have bosutinib and dasatinib available in Pakistan, but we have 4th generation asciminib available free of cost by Novartis. So what would be your choice, to switch, to continue, or to go for haplo?
Wow, you're giving an easy case there. That's a very challenging case. I'm glad that I've got Professor Bepi Saleh on the line as well, because he can help me out here. Look, it's a difficult decision. I'm always very worried when patients don't respond at all to the initial therapy, although in this case it was imatinib, but after 6 months he was switched to nilotinib at the presumably therapeutic dose for his size, presumably equivalent to 400 BD.
Sorry for the interruption.
And after 6 months, there was some evidence of response. You said 3%. So it'd come down from a high level, or was that no response at all? So do you know what he started at? What his PCR was at the start, or after the imatinib, but was it at a higher level?
At the start, there was just qualitative PCR.
Okay. And
after imatinib, it came down to 16 to 20%, not less than that.
So it has come down to 3%. If it hadn't budged at all, I would say this patient seems to have, primary resistance, and I'd be thinking very seriously about a transplant. When you start talking about a haplo transplant, then it's getting pretty tough decision. Look, asciminib, I didn't talk about asciminib. I probably could have talked. I'm assuming that Beppe is going to talk about asciminib. Yeah. We should have coordinated. Because I think it's a great drug. Obviously, I've been very closely involved in the phase 1 study and the phase 3 study, which demonstrates that it's better than bosutinib as a third-line therapy. I think in this situation, if I had a sibling donor, I would probably go straight to it, because I don't want to put any risk that this young patient will progress to blast crisis. But I'm assuming that with a haplo donor, you're probably talking about a transplant-related mortality of 20 or 30%, something like that. So I would probably in that situation look at asciminib. I don't know whether they'll allow it for a child. I have no idea. I've never requested it for a child. There's no data on children, so the dose would be a difficult thing. I think if I said if this was an adult, I would be comfortable to give them satinib. We have seen many patients who have been partially responsive to second-generation drugs who have had very good responses. So if you were able to get asciminib and the dose was, they were able to establish a safe dose, and you got a rapid response, got below 1% over the next 3 months, then I think that would be an interesting thing to pursue. It, at least, in the very least, give you some idea about responsiveness. If there was no response after 3 months to asciminib, I would think that the option would probably be a transplant. But I'm fascinated to hear what Professor SAGLIO feels about it.
Thank you, Tim. No, it's
Thank you very much, Professor SAGLIO.
Sorry, he hasn't been introduced yet, but I've got to bring him in here.
Yes, no, I think that I perfectly agree with you. You have to consider that this is a 12 years old child, and therefore the probability also discontinuing the therapy, at least at the moment, is almost absent. I would say I don't see any chance. So certainly the only way to get rid of the disease, and this should be such a young boy, the goal of the therapy that we want to pursue, I think that transplant has to be done. What already Tim suggested is that to try maybe for, I don't think that there are particular risk to also to try to use asciminib to obtain a better remission. That before transplant is always, of course, something which can help to maintain the therapy, and maybe can be also helpful at lower dosage to be continued after the transplant for a certain period of time, particularly if there is still minimal residual disease for the first 6-8 months after the transplant. But I would say that certainly transplant should be strongly considered for this boy or girl, I do not remember the sex. But what is very important is also, in my opinion, just to see. Of course, if there is a very good response to asciminib, you may also consider to wait a little bit longer, particularly because you don't have a sibling donor, if I'm correct.
That's right. 2 haplo donors, Beppe.
To haplo donors. So at this point, you can try to wait at this remission for quite a longer period of time, because I think that in 10 years or so, we will be able also to solve the situation of the treatment discontinuation. Yeah. But if I would say the response is not particularly exceptional on asciminib, I would transplant him.
Yeah, so we kind of broadly agree. I think I'm a little bit more reluctant to transplant because I do think that there's probably a 30% one-year mortality, and
Absolutely.
If that's not the case, then I'd be more enthusiastic. But in that situation, I think if we could see evidence of good response, and you may well get good response, and I'm assuming that you've excluded the fact that he's already progressed. I mean, he's now 3%, so I suspect he's still in chronic phase, but it'd be worthwhile to do a bone marrow. He may have clonal evolution at this stage, which would also push me towards transplant.
Biopsies will be important because sometimes also some blasts are only in small, I would say, groups, and therefore you can detect it only by bone marrow biopsy rather than by using other traditional way. So I think that this is a case in which there is no, we say, preferred treatment, but you have to follow and to tailor the treatment according to the different phases of the disease.
Yeah. And I think if Novartis are reluctant because they don't know what a safe dose is, I think the advantage of asciminib is that it's got a very broad range of tolerable doses. We use 200 twice daily in, excuse me, in the situation of a T315I mutation. So I don't think there's any great danger that, we're not going to be precisely at the right dose. I think they can make an estimate. So I hope that Novartis would agree to that.
Absolutely. I think so.
Thank you very much.
Because there is a clinical need. So why don't I to accept your proposal or your request?
Okay, so we have a few more questions for Professor Tim. So you showed a slide mentioning at diagnosis, there is no essential need for core biopsy. So the question is, if there are pockets of blasts, as Professor Saglio has mentioned, so you don't think that core biopsy should be done at diagnosis? Just the aspirate would be enough?
Well, the ELN recommendations say that it can be done. It can be valuable, particularly to look at the level of fibrosis. It doesn't mention looking for pockets of blast. It's not something that we routinely do. So if we don't do it, then we don't know whether we're missing something, I guess. But no, we've tended not to do it for some time now. And in fact, there are some groups arguing that you actually need an aspirate at all. But we strongly believe you need an aspirate. As long as that is good quality, that should be adequate. But it sounded like you might get a slightly different answer from Beppe. I'm not sure.
Okay.
Yeah.
So another question is, considering situation in Pakistan, Dr. Abdul Ali Wajid is asking, where only imatinib and nilotinib are available, what should we start with? What's your personal choice, Professor Tim?
Yeah, well, I mean, if you have the choice of both drugs, then that's great. They're two great drugs. I would tend to use nilotinib, where I saw there was a clear benefit, and that would be mainly in those patients with a high ELTS score. I think there the risk of transformation is getting quite high, and I think that's justified, except if the patient has major vascular concerns. And I would tend to use nilotinib, as I said, in the patients where I have a high priority for treatment-free remission, the younger patients. So I would rarely use nilotinib in patients over the age of 60. I think about that long and hard. I don't know whether the vascular problems that we see in Australia and the UK and US are similar in Pakistan, or whether you don't tend to see that sort of those sort of problems. So that would be an important issue for me. Is it just as bad a 65-year-old in Pakistan as a 65-year-old in Australia? Is the same risk of vascular events? If it is, then I tend to use that sort of general guideline. So 60 I find is a useful age to think about. Below that, I tend to like nilotinib. Above that, I would tend to prefer imatinib. But it's always weighing up the comorbidities, particularly the vascular comorbidities, the priority for treatment-free remission, and the ELTS score.
Thank you very much. Another question. Does BCR-ABL independent mutations have any impact on the course of chronic phase CML or advanced stage?
So BCR-ABL independent mutations are the things that that we're studying, and many groups are now studying at diagnosis. So you find about 20%. In fact, Sue Branford and Narani Shanmuganathan presented data at ASH suggesting that about 30% of patients have adverse mutations in addition to BCR-ABL at diagnosis. And in those 30%, the risk of progression was remarkably high. It was 20% or 25%. I have to look back at the actual numbers. For the rest of the patients, it was about 2%. So yes, I think they're incredibly important. And I think if we can validate that in much bigger data sets, it may well be part of the initial assessment that you'll do a quick screen for the adverse additional mutations, ASXL1, RUNX1. You'll do a quick screen of all those. Plus, Sue's group has identified these other abnormal fusions that occur around the site of BCR-ABL, which seem to be just as adverse for outcome. So I think in the future, you know, if we're going more towards a precision medicine approach, we'll use that to determine who gets a more potent drug, and who gets imatinib, and who goes straight to transplant if we get more confident about that sort of those sort of findings.
Okay. And the last question: what is more important, either high initial score and start second-line TKI, or start imatinib irrespective of initial score and switch based on first 3 months of PCR?
Yeah, well, I mean, the Title II study we did in Australia, we gave everybody imatinib, but we switched them to nilotinib if they didn't achieve optimal response. So 10% at 3 months, 1% at 6 months, 0.1% at 12 months. So it ended up about 15% or maybe 20% switched across because they didn't hit those targets. We were using a higher dose of imatinib, 600 milligrams a day, which I think does give you better responses, although it's never been proven in a randomized way. So that's not a bad approach. I mean, our overall transformation-free survival was 95% at 5 years. So it's a pretty good approach, but I don't think it's the best approach if you've got a major focus of treatment-free remission, because I think if you want to achieve that, frontline use for second-generation drug, I think is going to give you much higher prospects of achieving that within 5 to 7 years.
Thank you very much, Professor Tim, for sparing your very precious time for joining us on the behalf of Pakistan Society of Hematology. We are really thankful for your time, expertise, and an excellent talk. It was very enlightening for all of us, and it would help us more in the clinics for CML patients. Thank you very much. I think Professor Tim would not be joining us in the end. So we all thank you on the behalf of President and the whole country. We are really thankful.
It's a great pleasure. And I'd love to come one day in person if things get back to normal eventually. And just apologize to Beppe. It's getting very, very late here at 11:45.
No problem. I think that it was a very interesting discussion. And I can assure you that I've been in Pakistan, in particular to Lahore, at the beginning of this year. Was one of my last trips this year because of the COVID.
You're lucky.
It's a beautiful country that you cannot imagine how beautiful it is.
Can't wait.
Thank you very much. Thank you very much. We'll be introducing the audience to Professor SAGLIO and Professor TARIQ Mahmood Satti. So the second talk is by another expert of CML of world fame, Professor Giuseppe SAGLIO. I hope I'm pronouncing it right. He's the professor of internal medicine and hematology at the University of Turin, Italy. He's director of Department of Clinical and Biological Sciences at the University of Turin, and responsible for Division of Internal Medicine and Hematology at St. Luigi University Hospital. He's a very senior professor. He graduated from the University of Turin in 1975. Since then, he has studied internal medicine at the University of Turin, hematology at the University of Milan, and molecular biology at the University of Leiden and University of California. Dr. SAGLIO is the coordinator of the PhD program in molecular medicine and experimental therapy at the University of Turin. He is past president of Italian Society of Experimental Hematology and general secretary of International Association for Comparative Research on Leukemia and Related Diseases. He has published more than 500 peer-reviewed articles in the fields of molecular pathogenesis and hematological malignancies. And we are very much honored, sir, that you are here with us. And the audience you have is all the hematologists, hem-oncology residents, oncology residents, pediatric oncology residents, not only from Pakistan, but also from Nepal, from Bangladesh, few from India, and few from Afghanistan as well. So you'll be followed by another talk of Professor TARIQ Mahmood Satti, who is a transplanter. He has been commanding the largest Center of Transplant in Pakistan, that is Armed Forces Bone Marrow Transplant Center. He would follow you. So Professor SATTI has also joined in. So thank you very much for spending your time. Over to Professor SAGLIO for management of chronic myeloid leukemia.
Thank you very much, Miriam. It's always a pleasure for me to participate and to talk with doctors in Pakistan, but also in India, also in Bangladesh and so on. So I would like to start sharing my slides. I hope that you can see them. Okay, now we have to change a little bit, sorry. Yes.
Slides are visible very clearly.
Okay, we are starting from the beginning. Thank you very much. So I would say that what we have obtained during the last 2 decades in the therapy of CML is a very good overall survival. That of course is placing the overall survival after at least 10 years from diagnosis, I would say of more than 80% of the CML patients, which is very, very good, but is not perfectly matching, however, as shown in this German 4 study, that of a control population without leukemia. So we have still a small gap to fulfill. And the fact that it is not perfectly matching is due to the fact that we still have, at least in 1/3 of the cases, but 50% of the cases, particularly during the first 5 years from a diagnosis, patients who are dying because of CML. And we know that progression is the major cause of death of the CML patients, CML-related deaths. And you may see that these are mainly concentrated during the first 3-4 years from the start of the therapy and from diagnosis. Then there are still occasional cases later on, but these are mainly occurring in patients who are showing resistance to the TKI therapy. So, the first goal, as stated in the previous presentation by Team HUGHES, is still remains overall survival, of course, of the patients, and if possible also therapy discontinuation. But for the moment, this is a goal reserved in a rather limited number of patients, approximately maximum 20%, but probably even less, 15-10%. And the first goal is to achieve a major molecular response. Why major molecular response? Because it's considered the safe haven. Indeed, if you see the original data from the old IRIS study, is clearly showing that patients that after 12 months are in major molecular response or better have an overall survival which is almost 100%, which is after 10 years, which is an extremely good results. And at the moment we have at disposition, I would say all over the world. I know that in Pakistan you have only imatinib and nilotinib, but if we therefore decide to start in first-line therapy with imatinib, we have at our disposition a second-line therapy again, and nilotinib, and in other countries also dasatinib. Bosutinib is registered, at least in Europe and US, only for those patients in which nilotinib or dasatinib have a contraindication, like vascular risk of vascular events or of pleuropulmonary problems. Ponatinib is only registered for those patients who are resistant with the 359 mutation. As a third line, we have again bosutinib and ponatinib. We can also change the therapy from one second generation, let's say, to move from nilotinib to dasatinib or vice versa, but only for those cases who are intolerant to the therapy, because the percentage of patients resistant to a second generation TKI like nilotinib and responding, for example, to dasatinib, is only restricted to those patients having the mutations which are resistant to one TKI, are sensitive, still remaining sensitive to the others. So as a third line, we have mainly bosutinib and ponatinib for resistant cases. In specific cases, as the case that we discussed before, we can also start to think of stem cell transplant, but we will have this later on. As a fourth line, We have still at the moment the stem cell transplant for resistant cases is a strong indication. If not possible, we can try to enroll the patients in an investigational trial. Of course, this is only a problem of intolerance. We can change all the TKIs that we have at our disposition. If we decided to start in first line directly with second generation TKIs, like in your case, nilotinib, generally, if there is a resistance and not an intolerance, if there is an intolerance, you can change, but it's better to go definitely to the third line therapy and to consider, I would say, bosutinib or ponatinib. Jumping, this will become not a third line, but a second line, but jumping from a second generation TKIs to bosutinib or to a third generation TKI like ponatinib. In the near future, probably we will have also the possibility to use HUGHES, which is at the moment also available. So you have to strongly consider, after the presentation of the phase 3 trial comparing HUGHES versus bosutinib, to use, I would say in a compassionate way, also HUGHES. So, having a look at the 2020 European Leukemia Net recommendations, I would say that to start the therapy, there is not a precise, I would say, indication, because no TKI is recommended over the others because they have different efficacies a little bit, but also mainly also different, I would say, contraindications, and therefore I would say that this should be tailored according to the patients which is under observation. And however, a specification that is done in the recommendation is that generic imatinib is the most cost-effective option. Of course, if the drug is free, there are no problems, but if the patient has to pay just to have the drug, to start with imatinib is almost I would say the first choice to be done, even because, of course, the imatinib is there is a percentage of persons who are responding very well also to imatinib only. A second line therapy, again, no TKI is recommended over the others. But if there are specific mutations which are confirmed resistant to one TKI and not to the other, you can, of course, change or use the appropriate TKI. This also has I would say, a correlation, which is the need to test for the presence of mutations once the patients are resistant to the first-line therapy. Following resistance to second-generation TKI, ponatinib is preferred over the other second-generation TKIs during the poor chance of achieving durable responses with the other second-generation TKIs, and we already spoke about this aspect. And the exception is patients with a very high cardiovascular risk that, of course, should be considered with experimental agents instead. I think that at this point, HUGHES can really be a good choice for the data that at least we have at this moment. I would say that why there is a strong recommendation in the European Leukemia Net for imatinib. This was mainly due to the fact of the presentation of the data of the German CML study 4, in which is clearly shown that a very high degree of molecular responses using in particular a little bit higher dosages of imatinib. As you know, there is no direct confrontation apart this study, and that Team HUGHES previously said that indeed in Australia they already started with 600 milligram, not so different from what the German group has observed, which is just increasing the initial dose of imatinib, which is possible now because being a generic drug, of course, is less expensive. Indeed, you can obtain faster and deeper molecular responses, not only MMR, but as you see, also very good and early achievement of MR4, MR4.5. And after 10 years, the rate reported by the German group is really impressive. As you may see here, indeed, the percentage of cases achieving MR 4.5, MR 4 is extremely high. And this, of course, is supporting the fact that at least to try to start with imatinib and then to move to second generation TKI. This was one of the questions that I've seen before, and therefore this is something that maybe we can discuss later on. So these are the data again of the German group. We can jump over the slide. Why in certain situations, however, it's better to start immediately with second generation TKIs, but mainly because all the three main, maybe even more than three, different clinical studies, sponsored trials, but however, comparing second generation TKIs with respect to imatinib, have shown that with second generation TKIs, you are achieving a faster and deeper molecular response in terms of major molecular response, as you may see, and this effect is particularly evident during the first few years from the start of the therapy. Then there is the achievement of a sort of steady state, which is maintained also for the following 5 years after the start of the therapy. And this also contributes in the Ensnd study to a limitation of the number of the early blast crises that we know are particularly occurring in patients in the high or intermediate so-called and now we can say also LTS groups. And you may see here that the number of the blast crises registered, the progression of the disease registered on the core study is definitely lower, less than half. These are numbers, of course, but these cases are not so many, fortunately enough, in our days. And you see that there are halving the number of the patients who are progressing if you are using a second generation TKI like nilotinib with respect to what we have if we are using imatinib. Can we have a way to identify these patients with an inferior outcome or at risk of progression? As I told you, I would say certainly the old, we can already call it old, so-called score is in our day replaced by the most modern, I would say even better, European long-term survival score, UTOS, not European, sorry, UTOS long-term survival score, which is, I would say, a score based on parameters which are very similar to this, are exactly the same parameters used in the so-called, but with a different weight of the different, I would say, components. And this indeed allows, these are data that I presented attached this year, this allowed to reduce the number which of the patients who were falling in the intermediate and high-risk score from 60%, 64% to 41%. So here there is a mistake in the percentage, 60% to 41%. And particularly reducing also the number of the patients which are in the high-risk category. This is not only, I would say, an upgrading or downgrading of the from one risk so-called score to the following or the other, but is a profound remixing, as you may see, of the different risk categories. But what you can see already in this slide is that if we are considering indeed the patients of the so-called intermediate risk, we have that 72% of the patients are both intermediate in the LTS risk, but there is a percentage of 20% of the cases which are falling in the high risk group. And whereas the overall survival by the so-called risk is not distinguishing well between intermediate and high so-called risk, the LTS is definitely much better. You know that here there is an inferior outcome for the patients who are in the high ALTS risk group with respect to what we have in intermediate and 28%. So we have a lower number of patients falling in a higher, in a category with a higher risk of progression of the disease. And these are the different percentage which are obtained. But another point which is very important and that we have to consider, particularly in a young population, with the one in Pakistan with CML, of course, is just the fact that you can achieve deeper molecular responses, in particular MR 4.5, in a much higher percentage of patients. After 5 years, in more than 50% of the patients, if we are using second generation TKIs or versus imatinib. And we know that here I'm presenting the data of the nilotinib, but now there is a Japanese study which will be soon published and presented at ASH this year, which is showing that the two TK inhibitors of second generation, dasatinib and nilotinib, have exactly the same results in terms of deeper molecular responses. So why is it so important to achieve a deep molecular response? Of course, because this is the essential parameter to try to discontinue the therapy. And if we are using, this is another calculation from the Ensnd study, second generation TKI first-line therapy, we are achieving within 5 years almost 38% of the patients, so quite a good percentage, are patients who are ready to stop the therapy, and versus approximately half, a little bit more than half, if we use patients with imatinib, we treat patients only with imatinib, even if this is the traditional dosage of 400 milligram. So making all together, if we wanted to start to nilotinib, or in your case, in which only nilotinib is at your disposition, you can start, of course, but the therapy should be aimed to discontinuation of the therapy, because you have and the second point, which is very, very important, is that the nilotinib therapy, all the results that you can obtain with the nilotinib therapy are within 5 years from the start of the therapy. Then later on, because of the complication due to adverse events, are rendering this treatment no more useful, and I would say even dangerous, because it's introducing risk for cardiovascular events. So even in patients who initially do not have a risk for cardiovascular events. So at the end of the day, I totally share the opinion, which has been previously presented by Team HUGHES, that indeed second generation TKIs and even more powerful TKIs, which are a little bit also more associated with more adverse events, indeed should be used, can be used, and must be used in certain cases, but for a quite limited period of time and not for a lifelong period. So in the Italian population, as you may see, we are using second generation or imatinib in patients with different age. Here are just, I would say, are the data which have been obtained in an Italian registry. And you may see that subdividing the patients according to their age indicates there is a large prevalence of patients treated with second generation TKIs until the age of 60. Then above the age of 70, there is a large prevalence of patients treated with imatinib. And you see that indeed this is reflected also on the median age of the patients treated with imatinib, which is almost 70 with respect to 52 only with second generation TKI treated patients. You have to consider that indeed the median age of all patients in Italy is 60, because we are a very old population. After the Japanese population, we are the oldest population, the population with the median, I would say, age higher in the world. So which criteria these are a question for you, maybe, which criteria do you use to select imatinib or second generation first-line therapy? Age, risk category. We can discuss this later on. So, which are the requirements for TKI discontinuation? Could be very useful, as I told you, in a young population as the one that you have. Certainly, the CML should be in first chronic phase, and this happens, fortunately enough, in most of your patients. So the patients should be motivated to do it, but generally there is no problem, but we need to communicate which are the advantages and disadvantages of trying. But probably is the most important limitation is the fact that we need a standardized, I would say, way and very frequent way to monitor our patients by our qPCRs. And so also the turnaround of the results should be quite, I would say, in a strict period of time. Otherwise, you are receiving answers which are reflecting a situation which was 2 or 3 months before, and not the present situation of the patients in terms of molecular response. Of course, then apart these mandatory requirements, we need also optimal criteria, like a certain duration of the TKI therapy, at least 5 years, 3 years duration of MR4, or at least a 2-year durations of MR4.5. These are, I would say, optimal criteria. What does it mean optimal? That you can, even as a doctor, propose to try to discontinue the therapy in these categories of patients. But there are cases in which they are maybe more in need to try to stop the therapy, and therefore there are also minimal criteria, like no prior treatment failure, typical type of BCR-ABL transcript in order to have the possibility to monitor them, frontline or second-line therapy if due to intolerance only. These are quite strict requirements, in my opinion, but we can discuss later on. A certain duration of the TKI therapy, or a certain duration of more than 2 years of the deep molecular response. So there are situations in which if you are really in need, of course, you can not have the optimal criteria, but you can still try, even because we are increasing or lowering the bar of the possibility, but we cannot exclude that even in cases which are not totally falling in this optimal parameter, we can obtain at least 20-30% of probability of remaining TFR. So there are 2 studies which are telling us the 2 different strategies of virulence therapy. They should be adults with second, I would say, with chronic phase CML. One is the NEST Freedom, which patients were initially treated with nilotinib. They were achieving already, with a period not less than 2 years, MR4.5, which means that they were already in MR4.5 was good, but at least 2 years of a frontline nilotinib is required. It was required also to be in a very deep molecular response, MR4.5. They entered the study, they had a consolidation period of 1 year. Then in case of sustained deep molecular response, they could try TFR. And the results, as you may see, are very good. The TFR registered is present in approximately 50% of the cases, even with a very long follow-up now of 4 years. There is another study, which is also very important in my opinion, which is saying that patients who were not able to achieve under imatinib therapy, so who started on imatinib therapy, but that could not achieve a deep molecular response sufficient to try to stop the therapy, they were switched to nilotinib. And if they were reaching, I would say, MR4.5 after the switch, which means which is occurring in approximately 50% of the patients, according to another trial, which is called the NEST CMR. Indeed, these patients were enrolled in the study. They underwent a consolidation treatment with nilotinib at the same dose for an additional year. In case of sustained MR 4.5, they were allowed to stop the therapy. And the results on the long run are exactly the same with both studies. 50% of the patients are, after 4 years, still in treatment-free remission. So which are the main differences between the two studies? You may see that the time for MR 4.5 to study entry is approximately the same. The duration of the nilotinib treatment is approximately the same, a little bit longer in the Ensnd trial, but what is largely different is the total duration of the TKI therapy, the median duration, which is 3.6 years in the Ensnd freedom, so almost double, exactly double in the Ensnd trial. What does it mean? It means that if you are in a hurry to try, because we know to try to stop the therapy, because a very young lady, maybe she wants to become pregnant and so on, to have babies, it's better maybe to start with second generation TKI independently from the risk category, I would say, because are, of course, the low risk patients who are at higher probability of achieving, I would say, deep molecular response and then a successful TFR. So as this is in part what we said before, it has been said before by my team, two parameters we have to evaluate in the response. One is the depth, which is achieved, and one is the speed of response. And they go together. The patients who are responding fast are also those having deeper molecular response and those with the best outcome. And we know that, for example, just to be above or below the 10% BCR Abelson threshold after 3 months of therapy with all the types of TKI that we are using is corresponding to a better outcome. And we know also from the Australian group already published many years ago, as you may see, that those who are achieving very, very early response by 6 months, they have a very, very extremely high probability of achieving later on MR 4.5. Whereas those with the late achievement of an MR at 12 or 24 months, they have almost much less probabilities of achieving later on MR 4.5 on the longer run. So the initial halving time is the best predictor of TFR. This has not been yet introduced in clinical practice. I do not know if it will be, but certainly this is another way to look at the problem of discontinuation, which is not is telling us which are the probability of a specific patients to achieve and maintain a successful TFR. Why? Probably because if we are in non-optimal response and we have a lower, I would say, decrease of the BCR Abelson, therefore we are remaining at a certain point with a high residual BCR Abelson, we have, I would say, more subclones, which are typical, I would say, of the main pH positive clone, which are resistant or at least less sensitive to the TKI that we are using. If we are indeed in an optimal response, so we are achieving a very deep molecular response, the number of these resistant subclones is lower. And therefore, we have more probability of achieving or more probability of achieving a successful TFR. So I think that these are very, very important considerations. So the halving time, but also the fast achievement of very deep molecular responses is a criteria to say that the patients have a high probability of achieving a successful TFR. If we have to change TKI therapy to reach deep molecular response, when do we have to switch? Same rules for all patients. I would say that even in this case, we should be a little bit more flexible in terms of decision. What is recommended by the European Leukemia Net 2020 is that we have the classical subdivision in optimal, warning, and failure. And you may see that at 12 months, the minimum that you have to achieve is MMR after 1 year from the start of the therapy to remain in optimal response. But if you are not in MMR but you are simply in CCYR, and therefore you have a percentage of BCR Abelson which is 1% or between 1 and 0.1%. Indeed, you can also keep an eye on the patients and just look at which is the following response without switching immediately the therapy. This is a patient, we can say, under a spatial observation. Of course, if he's losing complete cytogenetic response, you have to try to change therapy. Indeed, the achievement of a deeper molecular response than MMR is not considered in the European Leukemia Net. MMR is sufficient for overall survival, but what has been said is that a change of treatment may be considered if MMR is not reached within 48 months. This is for the normal population, because there are still, I would say, some risk, maybe, even if very limited, of a progression of the disease, or the response is not so stable. But for patients aiming at TFR, you can also decide to switch, because of course you have to reach a deeper molecular response if you want to try this continuation. So it's largely dependent on the type of patients that you have in front. If there is a patients, I would say, older than 60, in which discontinuation maybe is not so compulsory, to try to discontinue therapy is not so, I would say, not a critical clinical need, you may also continue the same therapy because it's responding sufficiently well and there are very little side effects because it's tolerating the drug and so on. If you have a person in which it is becoming very important for you to try to achieve discontinuation of the therapy, you can switch the therapy. Indeed, the Italian GIMEMA recommendation are more demanding with respect to European 20, because in Italy, although we have a quite old population, there is, I would say, an increasing number of patients who are requiring to try to stop the therapy. And therefore, we are considering also to achieve at least for an optimal response, MR4 after 24 months. And if we don't have an immediate response, we propose an early switch to another TKI. So this is something that we can discuss later on. Do you consider not achieving MR4 after 2 years of therapy suboptimal response? So which are the guidelines that you are following at the moment? Then I wanted to talk a little bit about second line TFR, second line therapy. As I told you before, we have nilotinib, dasatinib, in specific cases also bosutinib or ponatinib. And what is recommended by European Leukemia 2020? No TKI is recommended over the others. The exception is the presence of specific domain mutations, as I told you before. And again, ponatinib is recommended as third-line therapy for those who are not achieving a good response with second-generation TKIs. But however, there is also a table which is very important, which is stating the contraindications that we may have for specific TKIs. As you may see, there are no strong contraindications for imatinib, but for dasatinib, there is a respiratory failure and prior concomitant pleuropulmonary or pericardial disease. For nilotinib, history of arteriovascular disease, coronary heart disease, cerebrovascular accidents, or peripheral arterial occlusive disease. Apparently none for bosutinib at the moment, but we have a shorter follow-up. Radotinib also is a drug which is available only in South Korea, but however, there are no contraindication. And for ponatinib, we know that is associated with high risk of cardiovascular events, so prior or concomitant arteriovascular disease. So what does it mean? It means simply that indeed, of course, these are not compulsory requirements to use, I would say, second generation TKIs, but to have the possibility to use a specific TKI. But of course, we must be particularly careful. In some cases, like for ponatinib, we are in the need to use ponatinib in specific cases, maybe with the 359 mutation. So we must pay particular attention, but also to the cardiovascular event, and maybe also to start preventive measures to avoid these cardiovascular events. So at the end of the day, with the classical flow of what we can obtain in CML therapy nowadays, if we start with imatinib with first-line therapy, we have 60% approximately of durable responses, but 40% of the patients require second-generation TKI. 50% of them are responding, but 50% require third-generation TKI. And again, the response rate is approximately 50%. So at the very end, we remain with some patients, and this is will be the talk of Professor Tariq Mahmood after me. But indeed, we remain as a third-line therapy that approximately 15–20% of the total CML population, which is particularly young in Pakistan, I would say also in all the Southeast countries, indeed are in need of a third-generation therapy. We have ponatinib, as I told you, which gave and is giving very beautiful results in terms of a complete cytogenetic response, in terms also of MMR, particularly in those patients with the 359 mutation, but even in the general population, the general resistant population is very, very good. And also with a certain rate of major deep molecular responses like MR4, MR4.5. And these responses are also durable because you may see that there is a stabilization of the responses, 60% of the responses obtained, that is in case of MMR, which is not a little amount, of course, it's an important amount after the second year from the switching time. And however, the problem is that I would say, this drug is associated with a high rate. It is a result of the PACE trial, in which indeed serious adverse events are occurring in approximately 26% of the patients for arterial and 5% of the patients with venous thrombotic event. And they are particularly, I would say, serious because they can be cardiovascular, cerebrovascular, and peripheral vascular events. And also there are other, like hypertension or other side effects, which are, at least, and this is a question that we will discuss with Professor Mahmood later on. Of course, it's difficult to understand if a patient who is achieving a very good remission with ponatinib should be maintained on ponatinib or has in complete remission to be moved to stem cell transplant. These patients have very little probabilities of achieving later on treatment-free remission using only TKIs. So I think that the only cure available for this patient is indeed represented by stem cell transplant. Of course, to transplant the patients in complete remission may be sometimes a difficult decision to take, even because in 10–15 years, maybe we will have other therapies which will overcome the need to undergo stem cell transplant. Well, we will discuss this later. So now, fortunately enough, we have a series of new drugs. I'm talking today about asciminib because this drug, which is a different inhibitor of BCR-ABL tyrosine kinase activity, has been presented at ASH this year. Asciminib is different with respect to the other TKIs because it's linking not to the ATP binding pocket, but the myristoyl site. This is causing, I would say, inactivation of the BCR-ABL tyrosine kinase activity. And being a different pocket, of course, the sensitivity of the traditional mutation, which are blocking or occurring within the ATP binding pocket or changing the conformation of the ATP binding pocket, do not interfere so much with the activity of this drug. But you may see that also there is a certain resistance to the 359 mutation, which requires also with asciminib higher dosage of the drug. But I would say this is a drug that also because is specific, much more specific for BCR-ABL, is not endowed with all the off-targets effects that we are seeing the traditional tyrosine kinase inhibitors, and it can also be associated with other tyrosine kinase inhibitor, more traditional link in the ATP binding pocket. So we have two different sites of action, so we can combine them together. And these are the future, I would say, path of the experimental clinical trials. So the first thing they was tested in phase 1, which the results have already been tested, and it was demonstrated that the complete hematologic response, the complete the achievement of MMR was very good, and indeed also in patients with the 359 mutation. And what is very important to be seen is that asciminib, patients who are in asciminib remain for a longer period of time on asciminib therapy, which means two things. With that the patients is well tolerated, because otherwise you cannot continue, and also that it shows some degree of, I would say, efficacy, however, because otherwise there is no sense to continue a drug if you don't have a response obtained. So now attached this here, we have the first report of the randomization of asciminib versus bosutinib, with the primary endpoint was a very, I would say, demanding endpoint, like MMR already at 24 weeks for patients who were not in MMR. The patients had to be resistant to at least 2, but more frequently even to 3 or 4 different TKIs, and BCR-ABL more than 1% at the screening period, but the therapy, the mutations 359 or V299L mutations were not allowed, because we know that bosutinib is not effective with these mutations. So the primary endpoint was achieved and presented already attached this year, with almost double the percentage of patients who achieved MMR on asciminib twice a day versus bosutinib, 25 versus 13. Also, all the other responses which are better. And what is also more important, that 70% of the patients undergoing a therapy with asciminib remained on the same on treatment, on the long-term treatment, whereas only 30% of patients who were treated with bosutinib. These results, however, are very important. They are introducing a new drug. So there will be other trials which are at the moment ongoing and not yet results available, but combining, as I told you, asciminib with imatinib for the patients who are not achieving a very good molecular response. I would say means very deep molecular response after a certain period of time. And this is the concept. We are trying to improve the percentage of those patients who are achieving the parameters, so to try to discontinue the therapy as an add-on therapy. This is asked for more, this trial, and we will have it soon. So there are also other first-line therapy and combination. Sorry for the phone, but okay, now already stopped. Thank you very much for your attention. I'm totally ready for your question.
Thank you very much, Professor Saglio. It was really a wonderful talk, a detailed discussion about all generations of TKI, first generation, second generation, third generation, and fourth generation. Very nice illustrations and very comprehensive talk indeed. So our question is, what possible effects can somatic mutations like TET2 or ASXL1 can have on TKI resistance? A question from our molecular biologist, Dr. Helen.
So can you repeat, please?
What possible effects can somatic mutations like TET2 and ASXL1 have on the prediction of resistance to TKI response?
Yes, this has been, there is a lot of work, as we were speaking before, particularly by the Australian group, but more recently also by other groups presented at ASH, in which indeed the presence of these mutations, in particular AXL-X1 mutation, are predictive of, I would say, an outcome which is not so favorable. And one of the questions was, do we need or do we insert this, I would say, this the presence of this mutation as we are doing for additional chromosomal aberration also is a warning, in the warning category at least, for in the European Leukemia. Certainly in the future, almost certainly yes, but for the moment not yet, because these are, I would say, analyses which are indeed restricted to a limited number of patients, so cannot be proposed to the vast majority of the centers treating CML in the world. But I'm sure that this will happen in the future.
Sir, another question is, what is the most considerable factor for prediction of lack of response after treatment-free remission? Once you achieve treatment-free remission, what factors cause reappearance of the disease? What is the most important factor?
The most important factor is definitely the duration of the deep molecular response. Duration of deep molecular response is probably associated, I would say, with also a lower amount of residual BCR-ABL and therefore pH-positive cells. And there are data already obtained with digital PCR, which is really saying that the depth of the molecular response, even beyond, of course, the MR4.5, but MR5, MR5.5, and so on, is always better. And this is roughly corresponding to the fact of the duration of the deep molecular response, which these are the two most important parameters. Therefore, and in addition, we have heard from Professor Hughes that even the so-called halving time is a very important factor that we need to consider. Although the halving time is not always easy to be performed in clinical practice, because you need, I would say, virgin sample obtained at diagnosis. Even the treatment or pretreatment, which is frequently, very frequently occurring with the oncocarbide and so on, is limiting the feasibility. So if you don't have an original sample at diagnosis without any kind of treatment, it's difficult to perform the halving time. But altogether, from the practical point of view, but certainly this is another very important, I would say, predictive factor for the successful TFR. And I think that all these parameters, we can say, aspects are going together. Faster the responses, deeper the responses, deeper responses, length of deep response may correspond to a lower amount of residual BCR-ABL. So these are the main parameters which link together, can tell us, and maybe can tell us also if the probability of remaining in successful TFR may be 80% or higher. If I can add an aspect, also these predictive factors are important, but at the end of the day, what we know that at the moment, the number of the patients who are indeed achieving TFR is approximately maybe 20% of the entire CML population. So the big problem is not is also to predict the possibility to achieve TFR, but this is a rather limited goal. In my opinion, what is important is to improve the percentage who can achieve a TFR, successful TFR. So we need to work also on this therapeutic side, not only in the predictive, the prediction of what is going on.
Thank you very much, our respectable Professor Giuseppe Saglio from Italy, for sparing your time, for educating us, and especially for motivating us all for TFR. I think it's high time that we should also try it with the better facilities for quantitative PCR, BCR available. Thank you very much for putting us wiser, sir. With this, we move on to our third talk of today's webinar. So we have on board with us Professor Dr. Major General Retired Tariq Mahmood SATTI, Hilal Imtiaz Military. He is one of the most experienced transplant physician of the country. And as I've already introduced, he has commanded the largest transplant center of the country, that is Armed Forces Bone Marrow Transplant Center, where I belong to. And sir is an expert of CML transplant, and today he's going to sum up the transplant options for chronic myeloid leukemia. Currently, he is working at Shifa International Hospital in Islamabad, the capital of our country. So we move on to Professor Tariq Mahmood SATTI's talk. Over to Jan SATTI, sir. Thank you, sir.
Thank you very much. Bismillahirrahmanirrahim. I'm visible on the screen or not?
So you are very much visible, and you have to share your slides. On the horizontal bar down, there is slide share option. Share your slides.
Yeah. So
yes.
I'm Bismillahirrahmanirrahim.
Please.
I'm very thankful to the this PSH team, especially General PARVEZ and Dr. Mehreen, for giving me this opportunity to share my views about the chronic myeloid leukemia, the role of bone marrow transplant. And as you know that the role of bone marrow transplant in chronic myeloid leukemia in the era of TKI therapy, it is actually the thing to be discussed. And nowadays it's a topic, a debate is going on, TKI versus bone marrow transplant in chronic myeloid leukemia. And I would say that in the history of chronic myeloid leukemia, initially, you know that the first disease in which the molecular basis of the disease have been picked up was actually the chronic myeloid leukemia. And at that time, it was a Philadelphia chromosome, and then onward, there were so many other diseases, and now we are on the era of the molecular basis of every malignancy. And the second thing is that the history and the future, I will just show you the slide in the next slide, that what was the treatment options in the 80s, 90s, and now after this new millennium, what are the treatments now available for chronic myeloid leukemia? And the second thing is that the slide which I am showing you is the building which is on the back side. It's a parent unit of mine, my main as a hematologist start from this institute, and it is one of the biggest institute in the country. The Armed Forces Bone Marrow Transplant Center, National Institute for Blood and Bone Marrow. The second thing is that, as you know, that in leukemias, when you start, the patient comes to you, like in acute leukemias, you are more focused toward the molecular testing, the bone marrow, cytogenetics, and because you have the focus that probably this is a patient for transplant later on. But chronic myeloid leukemia is now one of the condition when it comes to you, first time, you straight away go toward the other options, or the option of transplant is maybe considered as the third or fourth option in these patients. As I told you that I just showed you two slides of two very important celebrities who have actually suffered from this disease. One is in the past history, and one is in the future. So this is actually one of our very famous singer of 1970s and 80s, AHMED. He actually suffered from chronic myeloid leukemia in 1985. And at that time, the only option of treatment available with a curative treatment is bone marrow transplant. But that was a very costly affair. He started with this busulfan and so on and so forth. Then because he is from film industry, so if film industry people, especially one of our very famous singer, the Noor Jahan, contributed a lot to this patient. And he went to England, got a transplant in 1986-87, and he remained in remission. but unfortunately he died in 1999, probably because of relapse or complications of transplant and so on and so forth. The other person which is very famous, that is Kareem Abdul-Jabbar, one of the most famous NBA basketball player, having all the world records, only the records broken by Michael Jordan in the late 1990s. And he was actually 7 feet 6 inch. Kareem Abdul-Jabbar suffered from chronic myeloid leukemia in 2006. And he's on, then at that time, Newsweek gave that heading that now there is the patient of Kareem Abdul-Jabbar has suffered from the disease, and the new magic drug is available, TKI therapy, and he's on TKI therapy and still alive and having a healthy life going on. So this is the introduction. Just you see that in the classification of chronic myeloid leukemia, as you know, that the typical chronic myeloid leukemias are still having the 4 groups. One is in which there is a chromosomal Philadelphia positivity, BCR positive. The other one are the BCR positive, but the Philadelphia negative. And the third is that they are still typical because they have the chronic, a typical picture of bimodal peak, the chronic phase of the chronic disease of chronic myeloid leukemia, LAP score low and all that, but they are BCR Robertson gene and Philadelphia negative. So then, as you know, the chronic phase of the disease is very common. We've come across in which the patient had hepatosplenomegaly with bimodal peak of the cells, but most of them are tyrosine kinase sensitive. But some of these patients are resistant to first line, then you go to second line, as already been discussed by our worthy professors. So in the accelerated phase, then this is the challenge when the patients have developed about accelerated phase of the disease, and then you have to offer him the second, the third generation treatment, or go for the transplants. Options consider the possibility of transplant in these patients. And of course, then if the patient developed blastic transformation, then if the age is younger or the matching sibling donor is available, and if you can achieve the chronic phase of the disease, then the best option is, of course, the bone marrow transplant. This is just one of the scenario in which the patient passes through, that is the chronic phase, which takes about 4 to 6 years. Then it goes into the median, into maybe accelerated phase, and of course, and then the blastic transformation. And as the patient moves toward accelerated blastic transformation, especially if it is not on TKI therapy or if shows the resistance to TKI therapy, then the options left are stem cell therapy in these patients. And as you know, that the prognostic factor for the outcome of conventional chemotherapy are the marked splenomegaly, the circulating blast cells, the high platelet count, the basophilia, which is more than 15%, or eosinophilia, or the Philadelphia negative disease, or the older patients, that is more than 60 years of age. And these are the same, but some of the important, that is the increased number of basophils and eosinophils, and the area of bone damage from growth of leukemia is also one of the very bad prognostic marker. And of course, the multiple chromosomal changes occur in the other than Philadelphia chromosome. So the indications of bone marrow transplant in a patient of chronic myeloid leukemia is, one of the important indication is failure to TKI therapy, as already discussed, the first line, the second line, and so on and so forth. But the criteria is that the patient should have younger, relatively, say about 40, 45 years of age, having a matched sibling donor available, and there is no contraindication for, like no comorbidities for that. And the treatment failure is defined as if there is after 3 months, there is no hematological response, or after 6 months, there is a complete hematological response, but no cytogenetic response. Or after 12 months, there is more than 35% Philadelphia metaphases present, or after, say, about 18 months, less than complete cytogenetic response, So these are the candidates which you consider for the bone marrow transplant. And then again is one of the other is that if at any point the patient develops the resistance to therapy or BCR resistant gene appears, this is again is the indication for bone marrow transplant. And relative indications of transplant are the suboptimal response of the patient, which is defined as after 3 months there is no cytogenetic response, or after 6 months less than partial cytogenetic response, or after 12 months there is less than complete cytogenetic response, or at 18 months there is less than major molecular response. This is actually the criteria for consideration of the bone marrow transplant, but especially in the countries like the developing world, East, like Pakistan, India, and so on and so forth. But as the professors discussed already, that they have the other options after 18 months also to go for the third generation and so on and so forth. This is actually the scenario I just want to show over here, that at different stages of the chronic myeloid leukemia or in the different scenarios, the options which we have with the patient. In the chronic phase, the first line is, of course, the TKI therapy, first, second line generation, and you still consider the possibility of allogeneic bone marrow transplant if the patient not achieves major molecular remissions, say after about 18 months and so on and so forth. The other option is the scenario is accelerated or the blastic phase of the disease, in which you interim with therapy to achieve the chronic phase of the disease, and then the best option is bone marrow transplant. The other scenario is in which the patient has the mutation T315I mutation, in which you have who can offer the drug like ponatinib to achieve the remission. But I tell you that once you achieve this mutation with the ponatinib, still the best option in these patients is bone marrow transplant if they fulfill the criteria. The other options are scenarios are Imitative Failure in chronic phase, or no clonal evolution, no mutation, good initial response, but at the same time you go for the second line therapy, in which tyrosine kinase inhibitors, and if that phase or the patient had not achieves molecular remission or having some more mutational occurring during that period, then you consider the possibility of bone marrow transplant. The other scenario is clonal evolution or mutation or cytogenetic response to second line TKI. And again, in this scenario, you go for the second line TKI therapy or so ponatinib and so on and so forth. Once you achieve, and if the patient remains stable, then you can consider continue that treatment. Otherwise, second line in these patients again is bone marrow transplant. Then one of the scenario is old patient, that is more than 65 years of age. In these scenarios, the option of bone marrow transplant is almost nil. In this, you have to give salvage TKI therapy as long as possible you can give to these patients. And last but not least, one of the scenarios is imitative failure, emerging nations like Pakistan and India, Bangladesh, and so on and so forth, where there is only 2 drugs basically being sponsored available, like imatinib and nilotinib. And these patients, the option of bone marrow transplant is quite encouraging, especially in the younger patient, because the younger patients have a long period to go. And in these patients, this option is, I think, is one of the best options. So as you know that in the risk stratification has a Sokal score has all been discussed, but in bone marrow transplant, we consider these 3, 4, 5 factors on the basis of which you give the scoring to the patient. And on the basis of that, if the score is low, say about 0 to 2, then the prognosis are relatively good and the transplant results are on the upper side of the graph, that is say about 60, 70 to 80%, 70% roundabout. But if the score is say about 5 to 6 or 7, then the prognosis are very, very poor, I would say. And maybe the patient have a survival time or the disease-free survival is around about 30 to 40%. And these factors are important. That is the disease phase, the chronic phase of the disease. Then age, if they're less than 20 have the best chances, more than 40 have the poor outcome. The interval of diagnosis, if the diagnosis time is less than 1 year from the diagnosis to the transplant, the results are encouraging as compared to the more the period the patient had been suffering from the disease, then the chances of the success of transplants are minimized. Then, of course, the donor-recipient gender difference, in which there are different scenarios, like the male to male donor have 0 score, female to female donor 0 score, female to male donor again 0 score, but male patient to female donor have 1 score. So again, it's a bad prognostic marker. And one of the option other, which has not been mentioned here, is the type of transplant. Like in matched sibling donor transplant, the score is 0, but if the patient have a matched sibling, unmatched, unrelated donor like the MUD, the score is 1. So on these basis, you can predict the results of the transplant. And the conditioning therapies, which are differing with the passage of time, is improving. And also these conditioning therapies have also improved the outcome of these patients. I'll show you the graphs also in the next few slides. And as you know that the standard of treatment of conditioning is busulfone with cyclophosphamide. Initially, we used to give a high dose of cyclophosphamide, 200 milligram per kilogram body weight, which was very toxic. And the overall results were also not very encouraging from that point of view. Then with the passage of time, we decreased the cyclophosphamide dose, but at the same time, the results in the females especially, and in the older patients, above the, say about the age of 60, above the age of 40, the results were again not very encouraging, in the sense that patients develop more GVHD, especially acute, even chronic GVHD, and sometimes the crippling GVHD. So with the modification of that treatment with BU, PSI, along with ATG, with the addition of ATG, it has been observed that it will not inhibitory effect over the graft-versus leukemia effect, some or the other. And they have a relatively better results. And I'll show you the slides that in our own data of the Armed Forces Bone Marrow Transplant Center, in which after 2009, when we started this ATG addition of in these patients, the results were quite encouraging. Then, of course, these the last few are the reduced intensity conditioning therapies, which are basically been given to the old patients above the age of, say, about 45 to 50 or even 60. And in those patients in which there are comorbidities like cardiac or renal disease and so on and so forth. And these are actually the graph which is showing the 5 years follow-up of the patients of chronic myeloid leukemia on imatinib. And you see that the patients who are achieving the major molecular remissions are still about 70 to 80%. So that these are 20% of the people who are actually the candidate for the bone marrow transplant in chronic myeloid leukemia. And this is again showing that after the bone marrow transplant, the different results initially, which was the conditioning was not very refined or so and so forth. So the results of up to 2000 that shows that about in the accelerated phase that the transplant was done, the overall survival was about 40%, and disease-free and if the chronic phase, that is about 45%. But with the refinement of the new treatment of conditioning of chronic myeloid leukemia patients, now in 2009, the results showed that about, say, 65 to 70% of the patients can achieve long-term disease-free survival. And this is just to show that in the chronic myeloid leukemia patients who undergo transplants, disease-free survival is much different if the patient had some mutations other than Philadelphia chromosome. The more aberrations appears, and you can see that the results shows that about 3.5 to 4 years survival is less than 40%, about 30% with mutations. And overall survival is again showing that the quite not very encouraging with the additional mutations. And this is actually the latest slide of 2019, which shows the chronic myeloid leukemia survival after allogenic transplant. And you can see that the patients who have been in the chronic phase of the disease and undergone transplant, the results are very encouraging. The upper graph is showing around about 70-75% disease-free survival at 14 years of duration. Then the second line is showing the accelerated phase or the blastic phase of the disease, where once they achieved the remission again into chronic phase and then undergo transplant, their results are about to be 45 to 50%. But those patients who undergone bone marrow transplants in the blastic transformation phase, they have a very poor outcome, around about 20% outcome of these patients. So the other options in chronic myeloid leukemia is the DLI therapy, that is donor lymphocyte infusion. And it is very effective in chronic myeloid leukemia, especially if the patient has been picked up early in the molecular relapse. And if you start DLI therapy in escalating doses, you can achieve, again, remission in about 60 to 90% of the patients. And the only the complications which we come across in these patients is GVHD, which is one of the complications which can come and to be looked after. And the GVHD can be predicted in patients who are on DLI. It depends upon the dose of DLI which has been given, that is CD3 dose which has been monitored. Then, of course, the donor type, that is whether the donor is matched unrelated donor or if there's a female donor, multipara. So again, is the GVHDs can be predicted. And of course, not one of the other factors for GVHD in DLI therapy is the duration of transplant and the DLI to be given. So these are some of the factors which can predict about the response and of course the GVHD with the DLI. So the favorite regimen for chronic myeloid leukemia who have developed the molecular relapse or is one discontinue immunosuppression, starts interferon 1 million units per day for about 1 to 2 weeks, then start DLI with the initial dose of say about 1 into 10 to the power 6, means 1 million CD34 cells per kilogram body weight, and then increase the escalating dose depending upon the GVHD to 5 million per kg, then to 1, it's say about after 30 to 60 days. And if there is no GVHD, then you continue and achieve the target of deep molecular remission. And if the HLA mismatch starts with the DLI therapy, that is a haplotransplant if you have planned, or one antigen mismatch or 2 antigen mismatch transplant, in these patients, you have to give a lesser dose of DLI, that is, say 1 into 10 per 5 per kg, and then escalate the dose. And then you discontinue interferon after 2 negative reports of PCR for BCR-ABL genes, or at least 4 weeks apart. Otherwise, you have to continue this therapy. If the patient still not achieves a deep molecular remission or PCR negativity, then in this case, you can add GM-CSF for 10 days every month, along with the protocol which we are following till the patient achieves remission. And this slide just shows the DLI response in patients of chronic leukemia or in those patients who have been given other options. You see that graph showing that about 50% can have achieved remission with the TKI therapy and so on, so interferon and so on and so forth. But DLI therapy have the upper graph, which shows around about 80%, 75, 80% achieves remission with DLI therapy. This is just to sum up that in chronic myeloid leukemia, if the patient is in the chronic phase, yes, then you start with the TKI therapy. After evaluation, 3 months, 6 months with the RT-PCR for BCR-ABL genes. and evaluate after 18 months. If he achieves more deep molecular remission, then you continue with the TKI therapy or go for the second line, depending upon the response of the patient. If the patient is not in the chronic phase at the time of diagnosis, or when you have subjected him for study, then start with the higher dose of imatinib, say about 800 milligrams per day, or evaluate the patient, and then consider the option of allogenic transplant once the patient go into the chronic phase of the disease. And if there is a matched sibling donor and the patient is younger enough, and alternate treatments can be considered, or the other options could be considered, trial basis and so on and so forth. The contraindication for transplant, as already been discussed, that the TKI therapy response, the molecular remission, patient is achieving the molecular response, or the patient is uncontrolled blast crisis. So these are some of the contraindications. And of course, if there is some comorbidity like the cardiac disease, less than 40 or 40% ejection fractions, or the renal failure. So these are some of the contraindications for bone marrow transplant in patients. The monitoring of post-transplant patients is one of the methods by the BCR Abelson gene PCR testing. It is almost a similar way in which you are monitoring the patient on TKI therapy, like at 3 months, then 12 weeks, then 1 year, and at 2 years post-transplant, and so on and so forth. The other, especially do the on the bone marrow, but in the peripheral blood, you can monitor at 1 month, 3 months, 6, 9, 12, like in patients of TKI therapy, and then it's all depend upon. Then you can go to the second line therapy, like or DLI or whatever you plan later on. And indication for TKI therapy post allogenic transplant is one of the options, well, not option, but nowadays it's considered to be the treatment to be given, especially in those patients who've gone into the blastic transformation and then gone into the remission with the TKI therapy or interferon and whatever, and then underwent bone marrow transplant. These are the patients in which you have to continue TKI therapy after transplant, say about 3 months after transplant for at least 2 years. Similarly, the patients who have been gone into accelerated phase of the disease, or the patients who have been in the accelerated phase of the disease and then you have transplanted those patients, then they also require TKI therapy post-transplant. Similarly, those patients who have never on TKI therapy before transplant, these are also the patients who are remained on hydroxyurea, and then you have transplanted them. In these patients also, it can be recommended to give TKI therapy, but not for 2 years, for at least 1 year. And then is the high-risk patients, like high score, as I've already shown you a slide. If the score is say about 5 to 6 or 7, and then these are the patients in which you have to start TKI therapy post-transplant. And similarly, one of the option is in patients who are on DLI therapy after transplant because of molecular relapse. In these patients, it is recommended to start TKI therapy because they have a synergistic effect, and it's very, very effective. And in these patients to continue both DLI therapy along with TKI. Protocol for TKI therapy is post-transplant, about 3 months after transplant, say about 100 days post-transplant, and you give for 2 years, and the dosage, if you start with imatinib, say about 400 milligram per day, and for nilotinib, 600 milligram per day for 2 years. Same molecular monitoring is required as in TKI therapy in other chronic myeloid leukemia patients. So these are some of the, I've just shared you the data till December 2019 of chronic myeloid leukemia of my parent unit, Armed Forces Bone Marrow Transplant Center. And this is actually the 3 parameters were considered. There are 3. You are seeing the first is that the buccal, in the light blue is in which the patients received busulfons along with cyclophosphamide and ATG. The darker blue is in which the patients have been received bucy And the third one, the red one, is in which they receive GIUSEPPE, but with a size of 200 milligrams. The transplant-related mortality, you see that in patients who have been with ATG have the best results. Similarly, disease-free survival is better, and overall survival is about, you can see all results were with the addition of ATG in these patients. And this is the results showing that about 72% achieved overall survival out, and disease-free survival was 65%. But it was a whole from 2000 to 2001 to 2019. But after 2009, when we have started, refined our protocols, addition of ATG and so on and so forth, those are the results improves. You see that in the last 32 transplants, the overall survival was 79% and disease-free survival was 68.4%, which is very impressive in a sense that you can compare the results with the Indian bone marrow transplant results, which was 60.2% success disease-free survival, and China 65%, and South Korean results were 60%. And the complications which come across in these patients were like the acute GVHD, which was about 30% of the patients, but not very severe GVHD, like mucositis, hemorrhagic cystitis, and VOD. Because these are red lines showing that these are some of the complications which are comparatively more serious complications, but acute GVHD, out of the 25 patients we developed, which is 30% of the total, and grade 3 and grade 4 GVHD was only seen in about 8% of the patients. So the most, because in grade 3 and 4 GVHD, the outcome is very poor. Similarly, the chronic GVHD have been seen extensive only in about 2 patients, that is 16%, but limited chronic GVHD have been in about 83% of the patients. And these are actually the chronic GVHD, and of course the acute GVHD was in those period in which we were not using ATG. So the recommendation, the final, is that in the developing world, countries like Pakistan, India, Bangladesh, Nepal, and so on and so forth, it's still bone marrow transplant is one of the better options in the younger patient, where the patient is not, where the second line, third generations TKI are not available. Once the patient is not responding to or not achieved major molecular remission, then the plan for allogenic bone marrow transplant in these patients. Then the third, one of the important factor is the rate of fall of BCR, Abelson gene transcript level on the patient receiving TKI therapy at 3 months and 4 months helps in planning our transplant. And you can plan if the BCR Abelson transcript is not being very encouraging with the second generation TKI and so on and so forth. After 6 months. And so these are the patients in which the results are good, because the transplant, if can be done in the first year of diagnosis, then the results are very encouraging. And the other is that then TKI therapy is recommended post-transplant in patients of blastic phase or accelerated phase of the disease for at least 2 years. And last but not least, the patients after DLI therapy should also put on TKI therapy for 2 years. Along as I told you that it has got a synergistic effect on these patients. So this is all I want to share with you, and thank you very much for your for giving me this opportunity. Thank you.
Thank you very much, sir. We really enjoyed the talk, going through the 2 decades of transplant at our center and such a big number of transplanted patients for CML. I must tell you, this 83 patients of CML is a very big data, as nowadays, even the biggest centers of the world have not performed so many transplants, especially in CML. Due to
I just want to add that the person who is visible now, the General PARVEZ, he is actually the main figure behind this 83 transplants, because he from very beginning, and especially in the early 2001, 2, 3, 4 the basic the transplants were done in thalassemia, aplastic, and of course chronic myeloid leukemia. And he was actually the person who has refined these protocols and all that, and the results which I have shown you on the slide.
Thank you very much, sir, for this information. Jenna PARVEZ and Jenna SATTI both are among the pioneers of Armed Forces Bone Marrow Transplant Center. And most of the CML transplants have been done by Jenna PARVEZ and Jenna SATTI. Nowadays, the number of CML transplants are obviously third down the ladder. First is aplastic, then thalassemia, and then CML, followed by acute leukemias. Sir, thank you very much. Audience has asked many questions, which I've been answering typed question during your talk, and most of the questions have been answered in your slides. So any other questions? Jen SATTI is here. He would love to answer. Professor SAGLIO has left, and Professor Timothy has also left because it's quite late in Italy and Australia. So another question is, significant, sir, Jen SATTI, a question from you is significance of using interferon prior to DLI. Somebody has asked that second world data showed 30 to 70% relapse, then role of preemptive DLI plus minus TKI. So is there any data upon role of DLI and after DLI giving TKI, the percentage of relapse afterwards?
So the data, I don't have the data at the moment, but it is well known fact that the DLI along with the TKI therapy, if you add together, they have a synergistic effect. And the results, the deep molecular remission and the patient remains in the remission period 5 years for follow-up. I've seen in the EBMT results they're shown in the 2018 new book, 19 book, in which they have shown the graph also, in which the DLI therapy along with TKI was given, and the results were quite encouraging in this because of its synergistic effect, and they are being added in that phase. I don't know if you are asking for the interferon or something like that. You added that.
So there was an anonymous attendee who asked this question, so I couldn't explore the question in detail. Most of the attendees are having their names. So there's somebody who's asking the synergistic effect of DLI along with the TKI and any role of interferon after molecular relapse post-transplant.
Yeah, actually that this has actually been, I have shown you this in the slide also, that interferon is only added in those patients in who are not achieving the remission or molecular remission, and then you can add that interferon in those patients, because about 20 to 30% of the patients who have been given this interferon, they can achieve the molecular remission as a single agent also. So in these patients, again, it has been recommended. This is one of the study I've also been mentioned in, I think this, the new EBMT book of 2018, in which they have mentioned that addition of this interferon should be there 1 million units per day throughout, along with DLI and TKI. And so that is why, and the results are also been shown that it is slightly better with this option.
Thank you very much, sir. There was a lots of appreciation for today's webinar on chatting from different countries. Professor Ghulam Nabi Kakepoto was also here. So whoever is not among the panelists cannot have verbal communication with the panelists. So on the behalf of all those attendees, I'm conveying the appreciation to President PSH and the speakers. So on the behalf of President and Society of Hematology of Pakistan, I express my deepest gratitude to Professor TARIQ Mahmood SATTI, Professor Timothy, and Professor SAGLIO, who have already left. So with this, I hand over to President for the note of thanks. Thank you very much, the speakers, and thank you very much, a large number of attendees who attended till end. So 90% of the participants are still with us. Thank you very much. Over to Jenna PARVEZ.
Thank you, Marine, for excellently conducting the webinar. It's a great achievement. This was 7th in the series of webinars and the last one of 2020. And I think it's already quite late, and my deep gratitude and appreciation for all the learned speakers, Professor Hughes, Professor GIUSEPPE, and Professor TARIQ SATTI for taking out time for their excellent and very fascinating talks. Thank you so much, and thanks to all the participants who had the patience, who very patiently kept on attending the webinar for almost 2.5 hours, I'd say. And thank you very much. And Allah Hafiz from our side.
Thank you very much, everybody. See you all in 2021. Thank you very much, Sir Sati. Thank you very much. And thank you all the attendees. Allah Hafiz.
Khuda Hafiz.